Okay, we're going to do Chapter 27 now. This is the upper respiratory system. I'm going to talk about some of the problems of the nose and the paranasal. So a deviated septum is a deflection of a normally straight septum, which is the center part of your nose. It's usually caused by trauma, and that can be at birth or later in life. It interferes with airflow and sinus drainage. The symptoms are obstruction of breathing, congestion, frequent sinus infections. It can also be nosebleeds and facial pain. Our focus is on symptoms and pain relief. And if it's severe, we can do nasal septoplasty, which is a surgical procedure. Nasal fractures. And usually this is a trauma. Complications with this are airway obstruction, epistaxis, nosebleeds. We look out for meningeal tears, and that would cause a cerebral spinal fluid leak. And what we would specifically see with that is a clear fluid leaking from the nose. We can also see septal hematoma and cosmetic deformity. Manifestations, the patient would have pain. They would have crepitus on palpation. So you would actually feel here and you would feel the nose move. They're going to have swelling, ecchymosis, and deformity, and possibly difficulty breathing out of the nostrils. Fractures can also involve adjacent facial structures, such as the teeth, the eyes, or the facial bones. Extensive swelling may require waiting 5 to 10 days before any necessary repairs can be done with nasal fractures. So we're going to keep the head elevated. Our goal is to maintain the airway and reduce swelling. We can apply ice or cool compresses. Obviously, we're not going to apply a huge ice pack to the nose. So whatever the patient can be comfortable with, we apply those at 10 to 20 minute intervals. We can control pain with acetaminophen. That's better than using NSAIDs because NSAIDs promote bleeding. We'll do that within the first up to 48 hours. And then we would use a decongestant or saline cautiously for stuffiness. Rhinoplasty is the surgery that fixes this. It's reconstruction of the nose. It can be cosmetic or for trauma. It improves airway function. It's usually done on an outpatient basis. So those patients that have had trauma that have to wait 5 to 10 days for swelling to go down would come back in on an outpatient basis. The nose can be reshaped, lengthened, or shortened if it's done cosmetically, for cosmetic purposes. The nose can be packed during surgery and apply pressure to prevent bleeding, and that's usually removed the next day. An external splint can be applied, and that's usually left in place for a week. We want to teach the patient to keep their head elevated for 48 hours. This reduces and minimizes swelling. This is important for you to know. Keep the head elevated for 48 hours. This is to reduce and minimize swelling and pain. So for those patients that are going to go home, maybe we would suggest to them that they sleep in a recliner rather than going to bed. If they're in the hospital, we sleep with the head of the bed up. We do not want them to lay supine. Pre-surgery, we're going to instruct the patient not to take aspirin or any kind of NSAIDs for 2 weeks prior to their surgery. Stop smoking. That does not promote good healing. Immediately post-op, we maintain a clear airway. We always assess the respiratory status. We look at their pain management. We're looking for, over the surgical site for bleeding and infection. and edema. We're going to keep the head elevated again. We're going to teach the patient to expect edema. Cold compresses, elevation of head, restriction of activity. We don't want them to blow their nose, no swimming, no heavy lifting, no strenuous exercise. And it may take up to a year to recognize the full benefits of the surgery. Epistaxis is a nosebleed. Elderly patients with a nosebleed and O2 saturation of 89% is a problem. So if you've got a patient that has a nosebleed and their saturation drops to 89%, this is a problem. See me jumping up and down here. If you've got a patient that's elderly, they've come in with a nosebleed and their O2 saturation drops to 89%, that's a problem. Causes of epistaxis can be low humidity, allergies, upper respiratory tract infection, sinusitis, trauma, foreign bodies, hypertension, chemical irritants, overuse of decongestants, facial or nasal surgery, and tumors. And those over-the-counter decongestants, we don't want them to use, we don't want patients to use those for more than 3 days because they can cause a rebound congestion. So no more than 3 days for those. Conditions that, okay, so, and usually these surgeries are the cause of the bleed is in the anterior portion of the nasal cavity. So we want to keep the patient quiet. We want them in a sitting position. We want them to lean forward slightly, and we want their head tilted forward. We want to apply direct pressure. And this is important for you to know. We're going to pinch the entire soft lower portion of the nose 10 to 15 minutes. 10 to 15 minutes. This is the entire lower soft portion of the nose while they sit forward leaning. We want to ID the site of the nosebleed. Is it anterior? Is it posterior? We may apply a vasoconstricting agent. It can be packed. It can be cauterized. There is such a thing called an epistaxis balloon. We're going to watch for impaired respiratory status. We're going to watch their vital signs, their respiratory rate, their heart rate, their O2 sat, and their level of consciousness. And we're also going to look for signs of aspiration. And we watch and teach for signs of infection. The nasal packing may be left in for several days. Okay, so allergic rhinitis. A lot of that is going on now. It's a reaction of nasal mucosa to specific allergens. It's usually seasonal and happens a lot in the spring and the fall. It can also be perennial, and that's exposure to environmental allergens such as animal dander, dust, and mold. It can be intermittent. So if it is intermittent, that means that the symptoms are less than 4 days a week and less than 4 weeks per year. If it's persistent, the symptoms are more than 4 days a week and more than 4 weeks per year. Signs and symptoms are sneezing, watery, itchy eyes and nose, altered sense of smell, thin, watery nasal discharge. The patient will complain of a headache, congestion, pressure, cough, hoarseness, need to clear throat, and snoring. We want to teach the patient to avoid the triggers of allergic rhinitis. Again, this is important for you to know. We teach the patient to avoid the triggers of allergic rhinitis, whether that's a dog, the pollen in the trees, go west, young men, or whatever the allergen is, avoid it. If they can't avoid it, then medicate for it. acute viral rhinitis. This could be the common cold or acute upper respiratory tract infection. And this can be caused by over 200 different viruses, and that's probably what I'm suffering from right now. The average adult has 1 to 3 of these a year. It's usually spread by airborne droplet spray or by direct hand contact. Its susceptibility increases with fatigue, physical and emotional stress, allergies that affect throat and nose, compromised immune status, and quite possibly nursing school. Exercise can significantly reduce the number of upper respiratory tract infections. The signs and symptoms are runny nose, watery, itchy eyes, nasal congestion, sneezing, cough, sore throat, fever, headache, and fatigue. Symptoms usually last 2 to 14 days, but usually subside in 7 to 10 days. Unless you're in nursing school, then it's going to go on until the end of nursing school. Nursing management, we're going to get rest, fluids, good diet, antipyretics, analgesics. You can do warm saltwater gargles, ice chips, hot tea, throat lozenges, throat sprays. Again, we don't want to use those nasty nasal decongestants, over-the-counter decongestants, for more than 3 days. Antibiotics don't have an effect on viral rhinitis. We do want to teach the patient to recognize a secondary bacterial infection, and that would be a temp of greater than 100.4, swollen glands, severe sinus or ear pain, or significantly worsening symptoms. Influenza. This is a respiratory illness. It's very contagious. It's significant. It has significant morbidity and mortality rate. The flu season is September through April. Pandemic is defined as worldwide spread of a virus. We've seen this with avian and swine flu. Epidemic is a more localized outbreak. So limited to the United States would be epidemic. Influenza virus has the ability to adapt, change, and mutate, making vaccinations tricky. It's transmitted by direct contact or exposure to water and surfaces. Both people and animals can get this and transmit it. Incubation is usually 1 to 4 days, with symptoms lasting 5 to 7 days. Signs and symptoms are usually abrupt, with chills, fever, anorexia, malaise, generalized myalgias, and headache. It also comes with cough, rhinorrhea, sore throat. Older adults experience weakness and persistence of symptoms for weeks. Pneumonia is a common complication. It's diagnosed with a rapid flu test. If positive, antiviral drugs are given, but you have to take the drugs in order for them to work. Again, I think I said in the last lecture that if you do an assessment on a patient, an older patient, and you hear diffuse crackles in the basis of your lung assessment, this is noteworthy to let the provider know, because that's not a normal sound. You should get the flu shot, and you should encourage people to get the flu shot. It's redefined every year. We have inactivated and live attenuated flu vaccine. Right now, the CDC is working on what we'll be taking in the fall. It takes 2 weeks for the flu vaccine to be effective. In exchange for that, you're going to have a sore arm for about a day. The contraindications for the flu vaccine is if you have had a history of Guillain-Barré syndrome within 6 weeks of a previous vaccination, or if you have an allergy to eggs. And I think they've taken that risk out too, because you can get preservative-free vaccination now. The vaccine is meant to reduce the symptoms of flu. Sinusitis. This is an inflammation or hypertrophy of the mucosa that blocks the opening of the sinuses. It occludes drainage into the nose. Rhinosinusitis is a concurrent inflammation of the nasal mucosa. This can be nasal polyps, foreign bodies, deviated septum, tumors. Inflammation can also be bacterial or viral following an upper respiratory tract infection. Signs and symptoms include pain over the affected sinus, purulent nasal drainage, nasal obstruction, congestion, fever, malaise. Patients look and feel sick with this. Severe asthma can go along with this, with sinusitis for up to 50% of patients. So nursing management of sinusitis. Again, we're going to caution patients about using those over-the-counter nasal decongestants a maximum of 3 days. They can cause rebound congestion. We're going to teach the patient to reduce sinus inflammation and infection, and then control the allergens. If you're allergic to dogs, don't go around dogs. If you're allergic to cats, don't go around cats. Drug-appropriate therapy for symptomatic relief. Okay. Obstruction of nose and sinuses. This can be nasal polyps, soft, painless, benign growths that form slowly in the sinuses or nasal mucosa. Topical and systemic corticosteroids are used to shrink these. The endoscopic or laser surgery can remove them, but recurrence is common. So what causes these? We can also get foreign bodies in the nose and the paranasal sinuses. Things like buttons, beads, rocks. I had a daughter who put a rock up her nose because she didn't have a pocket when she was a little girl. Wood, cotton, beans, peas, anything can go up your nose. And chances are it's not going to come out. If it's left up there, it can produce a local inflammatory reaction, including nasal discharge, and eventually a purulent and foul-smelling discharge. This can cause pain and bleeding. So what do we do with this? Well, the first thing is we try and occlude one nair and blow it out the other, rather than try and push it through. So if a patient comes into the clinic complaining about a tissue being stuck up in there, we try and occlude one nair and have them attempt to blow it out the other nair. Okay, problems of the pharynx. Acute pharyngitis. This is an inflammation of the pharyngeal wall. This is tonsils, palate, uvula. This can be bacterial, viral, or fungal. Bacterial is strep. Viral includes 90% of what you see, and fungal is usually a result of prolonged use of antibiotics or HIV. So we kind of go about this in a elimination thing. Ask your patient if they've got, well, we can rule out the viral. Are they HIV positive or have they been on antibiotics for a long time? No, that rules out the fungal. If it looks like they've got the white patches on their tonsils, then we can do a rapid strep. And if that comes back negative, we know that 90% of these are going to be viral. And so if it's viral, then we're probably just going to go do symptomatic relief. But the important thing to remember is that for someone that comes in with anterior cervical lymph node swelling, a temp greater than 101.6, a sore throat, light patches on the tonsils, we would want to do a swab for a rapid strep. We always check for that. So symptomatic relief would be NSAIDs for pain, increased fluid intake, and gargle with warm salt water. And drink lots of hot tea. For those patients that actually have a fungal infection, such as Candida albicans, we teach them the swish and swallow technique with nystatin, which is usually a 5 cc swish and swallow. It's just a nasty little yellow liquid, thick liquid that you put in a cup, and they take it in their mouth and they swish it all around their mouth and cover the inside of it, and then they swallow. So it's a swish and swallow with oral nystatin. Peritonsillar abscess. This is a complication of acute pharyngitis. This is most often caused by beta hemolytic strep. It causes pain, swelling, and this is usually severe swelling, and can be a blockage of the throat, threatening the airway. This is sometimes a medical emergency. Also has fever, pain, fever, chills, and leukocytosis, and difficult swallowing. We admit these patients when they come into the ER. All right, airway obstruction. Airway obstruction is a medical emergency. It can be partial or complete. There are a variety of causes: food aspiration, foreign body, allergic reactions, edema, inflammation from infection or burns, peritonsillar or retropharyngeal abscess, malignancy, laryngeal or tracheal stenosis, and trauma. Those are all causes. What we see in the ER most often is food aspiration. Signs and symptoms are choking, stridor, use of accessory muscles, suprasternal and intercostal retractions, flaring nostrils, wheezing, restlessness, tachycardia, cyanosis, change in level of consciousness. And these are usually healthy people that all of a sudden are not able to move air in and out, and they panic. I can't say as I blame them. Our goal is to reestablish the airway. We can do Heimlich if that's appropriate. We can do a cricothyroidotomy. We can do an endotracheal intubation, although that's not usually what we do, because if they've got something obstructing their airway, chances are we're not going to be able to pass a tube down their throat. And then we can also do a tracheostomy. A tracheostomy is a surgically created stoma at the trach, into the trach, into the trachea, to establish an airway. It bypasses the upper airway obstruction. It facilitates removal of secretions. It's used in long-term ventilation management. It is permanent, or at least long-term. They're not always permanent. And it is done electively in the OR. The patient can eat with a trach because of its low position. The patient can talk with a trach once a fenestrated trach is put in place. Okay. Let's see. So surgically, okay. I think I just jumped ahead there. These are all the things that we just talked about. And here's a picture of a trach. I want to call your attention to the obturator. That is important for you to know. Rarely, but sometimes, the trach can come out within the first 24 to 48 hours after it's put in. If a patient coughs violently, or this string that's tied around the neck isn't tied tightly, it has been known to pop out. This obturator is a solid piece of plastic. It slips inside the trach itself, the trach tube. If you think about the IV catheters that you've been putting in or that you've practiced with, you have a metal needle that fits inside of a plastic cannula. And you insert the whole thing into a vein, and then you pull the rigid metal out, and you've got this flexible little plastic catheter in here. Well, the obturator takes the place of the metal needle. It provides rigidity and gives the shape to the tube. And you need to put that into the trach, into the tube of the trach, so that you can pop that back in if you need to. So when this patient comes back from the OR, that obturator should come with him. It'll come in a plastic bag, and you take that up to the head of the bed on the wall so that it's in plain sight. If you have to use it, it will be emergent. It's rare that it happens, but if you have to, you need it, and it should be taped to the head of the bed, the wall at the head of the bed. And that will be a test question. If the trach tube is dislodged, you immediately try and replace it. You have to place the obturator into the outer cannula and try and reinsert it. If you can't reinsert it, then you call for a rapid response, call a code, I don't care, anything to get you some help. Chances are the patient is going to be able to breathe. You just get a bag valve mask, and instead of putting it over the patient's nose, you put it over their stoma and breathe here for them. But that obturator is important. Okay. Here's a picture, and we discovered in class Wednesday night, for those that did come, that my slides are wrong. This is not the esophagus, this is the trachea. Some of the books are right, some of the books are wrong. But this is the trachea that this is inserted with, and the slide says esophagus. Okay, so anyway, this is just a picture of how a trach is inserted and where it's inserted. Okay, another thing we talk about are laryngeal polyps. These are polyps that develop on the vocal cords from abuse. That could be excessive talking, singing, irritation like smoking, or intubation or chemicals. Hoarseness is the primary symptom. Usually it's conservative treatment, such as voice rest or adequate hydration. Surgical removal is another option. Sometimes that doesn't work so well. Just ask Julie Andrews. She had laryngeal polyps removed and was not able to sing after that. Joan Rivers actually had the same surgery, and she ended up dying. So it's nothing to be messed with. Okay, so here's a picture of suctioning a trach. You wear gloves. This is a very messy procedure. We hope the patient with the trach is well enough that he or she can cough their own secretions out. If not, you have to suction them. The important thing to remember is that once you start suctioning, you hold your breath the entire time you're suctioning, because if you're holding your breath, you know when you run out of breath, they're out of breath. I hope I said that right. So to start the whole process, you're going to bag them for about 30 seconds before you start any kind of procedure. You'll glove, you'll get a little container of saline. You'll have one hand that's clean, one hand that's going to work the bag. You'll bag them. You'll lubricate your catheter. As soon as you finish bagging them, you're going to start holding your breath. You'll insert the catheter down their trach. Insert it as far as you can go. As soon as you start pulling out, you'll put your thumb over the catheter hole, and that creates suction, and you'll rotate it as you come out. You should not have suction on for more than 10 seconds. This whole time, you are holding your breath because they're not breathing, so you can't breathe. If you get out of breath, they're out of breath. Okay, so that's suctioning. And here's a picture of a patient that has an inline suctioning catheter. These are a little bit easier to handle. We like those. Okay. Again, if we displace the tube, we grasp the retention sutures or with hemostats, and we insert the obturator and replace the tube and lubricate with saline and insert at a 45-degree angle. I hope you never have to do this. But we want the obturator at the head of the bed. Okay, the patient should be in semi-Fowler's position. If a stoma comes out, and then when we are actually removing the trachs, we start with a large trach, and then when they're getting ready to take the trachs out, they'll move to a smaller size, a smaller size, a smaller size. And then when they finally come out, they'll just cover this stoma with a piece of gauze, and it will seal itself up over the 4 to 5 days, is what this slide is telling us. And then our last slide talks about problems of the trachea and the larynx. We've already talked about laryngeal polyps, head and neck cancer. Patients that have been identified as heavy smokers, you should also ask them about their alcohol consumption. If you have one, you might have the other. That doesn't necessarily mean that you will, but you should always ask them if they're a smoker, do they have a history of alcohol consumption? That will be a test question. Also ask about alcohol consumption if you have a smoker. Head and neck cancers usually go along with smoking and alcohol. They're highly associated to tobacco use, and alcohol is another risk factor. Sun exposure and radiation therapy, asbestos exposure, and industrial carcinogens are another. And poor oral hygiene are other risk factors. Men are twice as likely to be affected as women. Signs and symptoms depend on the type. We can see white patches on the mouth, ulcers that do not heal, hoarseness that lasts for more than 2 weeks, laryngeal cancer, lymph in the throat can change in vocal, or a lump in the throat or a change in the vocal quality, a sore throat that doesn't go away, ear pain, swelling or lumps in the chewing difficulties, swallowing difficulties, unintentional weight loss. My dad actually died of esophageal cancer, and that is directly related to drinking. Alcoholics and esophageal cancer go hand in hand. He had also been diagnosed with leukocytosis, which is the white patches on his lips. He was also a pipe smoker, but they weren't going to do anything with that because the esophageal cancer was the more serious, or leukoplakia, I guess it is. Early detection is key. We do a visual inspection of oral cavity. And they'll do a biopsy. They'll do visual inspection with a laryngeal mirror or a flexible nasal pharyngeal pharyngeoscopy. They can do CT, MRI, or PET scans. The goal is to stage this. They need to know, based on the tumor size, the node involvement, and the extent of the metastasis, the TNM, and then they'll grade it from 1 to 4, with 1 being the least involved and 4 being the most involved. Stages 1 and 2 are potentially curable with single modalities that include surgery, radiation, and chemotherapy. Stages 3 and 4 are treated with combinations of surgery, radiation, and therapy, and chemotherapy, and targeted therapy. Nutritional therapy is also considered with these patients. So nursing management of the head and neck cancers. We look for effective airway clearance related to these patients. There's always a risk for aspiration related to the presence of a tracheostomy tube, if there is one. There's anxiety related to a lack of knowledge regarding the surgical procedure and pain. The outcomes we're looking for are a patent airway. We don't want a spread of cancer. We don't want complications related to therapy. We want adequate nutrition. So let me skip down here to a laryngectomy, because that's one of the most radical surgeries that we can do. A radical neck dissection for a laryngectomy, cancer of throat cancer. It's going to be a permanent. That's going to leave the patient with a permanent opening in the neck. It's also going to remove their vocal cords. And this type of patient is going to need some type of speech or voice restoration. They're going to need some long-term therapy, and this will be a test question. So know that patients that have a laryngectomy and radical neck dissection for cancer, cancer of the larynx, will have permanent opening in the neck and need some type of speech and voice restoration. They're also going to need some social rehabilitation, because they're just not going to be the same. All right, so I think that's about it for my notes, and I think that's about it for this chapter.